So good morning. Thank you, Aoife, for the introduction, and thanks very much for the opportunity to speak this morning about Huntington's disease. And I promise I don't plan to dwell on history and to make this talk one that is practically focused and useful for healthcare professionals dealing with people with Huntington's disease in today's world. But with this disease, context is everything. It's everything to the patient who tries to navigate a world in which their disease is poorly understood and which assigns to them the same fate of many generations past before them. It's everything to their children who try to plan their lives, both as a caregiver and as an at-risk person, where every decision they make, decisions about their future, decisions to pursue a career, to marry, to plan a family, are all made in the shadow of the enormity of this disease. So therefore, context should be everything to us, the healthcare professionals, who are trying our best to look after people with this disease on a day-to-day basis. So Huntington's disease was first described in 1871 by an American physician, George Huntington, and many of the features of the disease that he described at that time hold true centuries later. He described it as a progressive disease characterised by chorea, by progressive cognitive impairment, and by psychiatric decline. He described the heritability of the disease in a time before anyone really knew anything about Mendelian genetics. And if anyone ever finds themselves in need of a humbling, just remember that George Huntington was 22 when he published this seminal paper 1 year after graduating from medical school. And you might think then for the next 100 years or so that not a lot happened specifically in the world of HD, but that wasn't without good reason, because our understanding of the evolution of modern genetics was unfolding during that time period. And while Mendel's first theories were published in the 1860s, we had a long way to go from pea plants to human genetics. And in the 1950s, the double helical structure of DNA was described. And finally, we entered the era of modern-day molecular genetics. During that same decade, a Venezuelan physician called Americo Negrete was studying a disease endemic to the shores of Lake Maracaibo in Venezuela, known locally as El Mal. Negrete, while working in Maracaibo, encountered people in the streets who had a peculiar gait disorder and involuntary movements. He comprehensively catalogued their cognitive and behavioural features, as well as their clinical examination findings. These people were seen as a problem by the Venezuelan government, and they were referred to as the dancing mania. Negrete was advised not to enter the villages in which these people lived. They essentially lived an ostracised and shunned life on the fringes of society. They lived in villages without medical care, without police services, without schools or teachers. And they were essentially ostracised and shunned from Venezuelan society at the time. But Negrete's work, although initially met with resistance from, of course, the Venezuelan government, but also from the local scientific community, was initially met with a lot of resistance. His work went on to reclassify the dancing mania as Huntington's disease, and it put Lake Maracaibo on the map as the region in the world containing the world's largest population of people living with Huntington's disease. And his work would go on to form the foundation of the Venezuela Project. This was led by Dr. Nancy Wexler and the Hereditary Disease Foundation, who in the late 1970s embarked on a 20-year mission to that would ultimately lead to the discovery of the HD gene. Nancy Wexler was an American neuropsychologist and geneticist who devoted 20 years of her life to leading teams of researchers to the shores of Lake Maracaibo in search of a greater understanding of this disease. Throughout their time there, they studied 4,000 blood samples from individuals. They traced the disease through 10 generations and 18,000 people. And ultimately, in 1993, their work led to the discovery of the Huntington's disease gene, which was located on chromosome 4. This was a huge milestone in the history of Huntington's disease, and probably the greatest discovery since its original description 100 years earlier. Not only was it a huge milestone for the field of Huntington's disease, but many of the molecular techniques that were used in the discovery of this gene went on to inform discovery in other hereditary diseases down through the years. So there's no doubt that this is a resounding success for the medical community. In 1993, we now have a direct gene test for Huntington's disease. So from the perspective of the clinician, the scientist, and the researcher, this can be seen as nothing other than a success story. However, I think we've skipped a couple of slides here, sorry. However, for the HD community, it of course was also a success story, but it's one that's coloured through an entirely different lens, where people living with the disease are now faced with a choice between living in hope or living with clarity. And this is a photograph taken of a family affected by Huntington's disease in the 1940s. And the context in which this family will go on to make decisions about testing is not yet vastly different to the context in which today's families sitting in front of you in your clinic in 2025 will make those decisions. The man in this photo is Milton Wexler. He's the founder of the Hereditary Disease Foundation, which played an instrumental role in coordinating hundreds of international researchers with the Venezuela project leading to the ultimate discovery of the gene, and that foundation continues to fund collaborative HD research today. To his left, his wife Leonore Wexler, who was diagnosed with Huntington's disease at the age of 58, and they are photographed with their two daughters, Alice and Nancy Wexler. Nancy would go on 1 year after her mother's death to devote 20 years of her life to discovery of the gene. And after this groundbreaking discovery, Nancy spoke of the implications of this for her family. She said, "The breakthrough in Huntington's disease research has caused an echo of the crisis that confronted us when we first discovered the illness. Taking the test is both an intensely personal, individual decision and a family decision. And with each test, each roll of the dice, the family holds its breath." At the age of 74, having been symptomatic for at least a decade and having never taken the test that she played an instrumental role in discovering, Nancy Wexler publicly acknowledged that she was affected with the disease. She openly acknowledged the stigma and ostracisation faced by people living with Huntington's disease, and this is an article that was published in 2020. It reminds us that people, even living in today's modern world, are followed by stigma and shame that has been building for generations. It is not something that was left behind in the early 1900s when the eugenics movement saw thousands of people living with HD involuntarily sterilised. In a time where an eminent biologist, Charles Davenport, wrote that families with HD should be subject to surveillance, immigration restrictions and compulsory sterilisation. As recently as the 1960s, the then director of the World Federation of Neurology described the hereditary nature of the disease as a hideous snowball that was unlikely to die out naturally. And this study was published in 2009 and is a study of pre-manifest people with Huntington's disease assessing what they felt their levels of discrimination were. 40% of people in 2009 with pre-manifest HD described experiencing discrimination from insurance providers, mortgage providers, from family members, in social settings and in the workplace. And this shame and stigma is something that clouds family histories, that leads to incomplete family trees. It leads to falsely low prevalence rates of the disease, and it's something that we must all be aware of. So, as promised, we will now move into the more practical aspect of the talk, where we will speak about the biology of HD, the natural history, the diagnosis, and a little bit about future therapies. But I think that as healthcare professionals, we must always be mindful of the context in which the person living with HD views their disease. They are experiencing their disease through the lens of centuries of stigma and of generations of loss, of suffering, of hope and of care that we can only try to understand. So, moving on now to the practical aspect. So, I'll speak a little bit about the biology of the disease. So, thanks to years of dedicated research, we now know that the Huntington gene is located on the short arm of chromosome 4. and that the Huntington gene encodes for a protein called the Huntington protein. In the Huntington protein, there is a string of amino acids called glutamine, and these are necessary for the normal functioning of the protein. The DNA code for glutamine is CAG or CAG. So everyone in this room has a number of CAG repeats in their Huntington protein that will allow them to develop a normal Huntington protein. In the European population, interestingly, the baseline healthy general population has a slightly higher number of CAG repeats than in other populations where there is a lower prevalence of the disease. So having 18 to 19 CAG repeats, which is what the general population in Europe have, does not mean that that is going to cause disease. It is in the non-pathogenic range. But the problem is that in people with Huntington's disease, their CAG repeats expand into a disease-causing range, and the longer the CAG repeats, the greater the propensity for disease. So the genetic continuum of HD begins at 27 CAG repeats, and anyone who has over 27 CAG repeats demonstrates something called somatic instability. So this essentially means that the CAG repeats are unstable, and as they are passed down through generations, they can expand and ultimately end up in a disease-causing range. So people who have 27 to 35 repeats do not have symptomatic disease, but they do have unstable repeats. People who have CAG repeats in the range of 36 to 39 demonstrate something called reduced penetrance. So that means that people who have CAG repeats in this range either may or may not develop the disease. And this is really where the clinical continuum of the disease begins. People who have 40 or greater CAG repeats have a 100% likelihood of developing the disease with full penetrance. So in the average lifespan, 100% of people with this number of CAG repeats will develop the disease. And then you have people who have a very high number of CAG repeats, so more than 56, and these people have a very early and severe form of the disease called juvenile Huntington's disease. And once we enter into that genetic continuum for HD, so more than 27 repeats, with transmission to each successive generation, the CAG repeats will increase or decrease by one or a few repeats, but increases do tend to predominate. And many people in this room will be familiar with that phenomenon of anticipation, which is where in successive generations we may see earlier onset and more severe forms of the disease. But this is often caused by very large jumps in CAG repeats, and that is actually quite a rare occurrence and usually occurs when transmission is down through the paternal line. But our number of CAG repeats doesn't only determine whether we're going to develop the disease or not, but it also determines the rate of pathogenesis. And that's nicely depicted in this graph, where we can see that the age of onset of motor diagnosis is directly correlated with the number of CAG repeats. But to think of Huntington's disease as beginning at the time of motor diagnosis would be incorrect, because we know that for decades before motor signs appear, there are disease-related pathological changes occurring at a cellular level. So in the years before the development of the motor diagnosis, we have these pre-manifest and prodromal phases, during which time we may not be exhibiting motor symptoms. And I think the prodromal phase is particularly interesting for this audience because a lot of people in the prodromal phase have symptoms of cognitive decline and neuropsychiatric decline that predominate and can be present for up to 15 years before somebody presents with motor symptoms. But while it is important to think of the biological lifespan of the disease, so from the stage 0, where essentially you have 40 CAG repeats but you don't yet have symptoms, all the way through to manifest disease and functional loss, it is also important to think of the disease in this context where life milestones and disease milestones are intricately related for a person with HD. So take the typical life of someone with HD. In their teenage years, their affected parent may be diagnosed. This, of course, causes problems for their psychological health, their social relationships, their spiritual and religious well-being. But then they finish school, they begin to gain independence, they enter adulthood, they pursue a career, they may meet someone and marry, and then they may consider starting a family. And the perspective of the spectre of the disease, again, raises its head, and this causes anxiety and fear when people start to think about the concept of predictive testing. As this person then progresses into adulthood and their parent becomes more unwell, soon after the death of their affected parent, they may begin to experience symptoms themselves. And this leads to, obviously, a great decrease in all quality of life metrics. But interestingly, in the period after diagnosis, their psychological well-being sees an improvement. And I think that speaks to the importance of a timely and accurate diagnosis in rare neurodegenerative diseases like this. So I now want to speak just a little bit about how the practical aspects of supporting someone living with Huntington's disease throughout their lifespan, and starting with that pre-symptomatic period where people may be faced with heavy choices about planning for their future. And we heard from the Wexler's story that the decision to undertake predictive testing is a very personal decision and a very emotive one. And actually only 15 to 20% of people with HD do choose, or who are at risk of HD, do choose to undergo predictive testing. In Ireland, if somebody wants to pursue predictive testing, this happens through the clinical genetics service at Crumlin, and it really shouldn't take place in any construct outside of this, because the appropriate supports are provided by the clinical geneticists and are necessary for somebody navigating this sensitive time in their life. So if somebody is referred for predictive testing, they will be offered 2 sessions with a genetic counsellor 4 to 6 weeks apart in advance of testing. If further supports are needed, like further sessions with the counsellor, a psychologist or a psychiatrist, this can be arranged. If somebody chooses to undergo testing, their results will be delivered at an in-person appointment with a genetic counsellor 6 weeks later, and then they will receive 2 further follow-up appointments, if needed, with the clinical genetics service. If a positive result is identified, an onward referral to neurology is made. So, what does the data say about predictive testing? Well, we know that regardless of the result, the period after testing does result in increased distress for people. Those who receive a positive result develop concerns about their future, about their care needs, and about how their family will handle this. Those who receive a negative result may experience feelings of guilt about what is seen to be a family disease. But I think as we enter an era where genetic testing is likely to expand into other neurodegenerative diseases, and in time we may see the likes of ApoE4 testing entering the clinical continuum of Alzheimer's disease, we should always draw on the experiences of Huntington's disease, where predictive testing and pre-symptomatic testing has been in play for so many years at this point. And what the data does show is that while there is an initial period of distress, people do tend to adjust to their diagnosis, and in particular those who choose to test for a specific reason and a specific motivation tend to do better than those who test just for certainty or clarity about their future. And one of the main reasons for testing, or a big reason for people choosing to undergo testing, is for family planning reasons. And I'll speak just briefly about pre-implantation genetic testing, which some people may choose to undertake. But this is not a service that's publicly funded in Ireland. It costs between €7,000 and €9,000 for a single cycle. So it's a very expensive and time-consuming process, and it is not something that may be accessible or desirable for all, but you may meet people in the clinical setting who are interested in this, or who have pursued this privately or abroad. So now we're going to move into the phase where we see people in the symptomatic point of their disease, either the prodromal or the fully manifest phases of disease, and we're just going to talk a little bit about how to recognise those symptoms. And the typical diagnostic process for HT begins with a clinical evaluation, for which I can assure you your stethoscope will be a fairly mute instrument. And then, of course, a detailed family history, followed, of course, by genetic testing. So when we think about the clinical evaluation of Huntington's disease, the first thing that comes to mind is usually the motor features. But what I want to convey in the next few slides really is that the motor features are the tip of the iceberg. When somebody presents with motor features, their disease is already usually well established. and they may have been experiencing many, many years of cognitive and psychiatric decline in evolution. And actually, even when you speak to family members and caregivers, the motor features are the least burdensome in comparison to those cognitive and neuropsychiatric symptoms. So I'm not going to dwell on them, but I'm just going to speak a little bit about what we tend to encounter. So in adult onset Huntington's disease, the most common manifestation is, of course, chorea, these involuntary movements that can be quite subtle and easily compensated for by people in the early phases of the disease. Parkinsonism is not something we typically associate with HD, but actually, as adult onset HD evolves, Parkinsonism can become quite a significant feature and is actually a greater determinant of disease progression than the chorea itself. Finally, people can present with unusual gait patterns, so these can be quite complex and really difficult to characterise, because you can have Parkinsonism, chorea, you can have rigidity or dystonia or ataxia, so often the patterns can be very unusual and hard to kind of fit neatly into one box. The cognitive features then, as mentioned, can be in evolution for so many years before the motor symptoms present, and are a determinant of progression, unlike the psychiatric and behavioural symptoms, which can fluctuate throughout the course. So these cognitive symptoms can predate the motor diagnosis by up to 15 years. They represent a progressive deviation from baseline. And typically the profile is that of affected frontal domains. So you may see people who have problems with attention, mental flexibility, planning, emotional recognition, or impaired insight. And the latter can be really problematic actually in terms of accessing care in the earlier phases of the disease. And furthermore, deficits in social cognition can lead to breakdown in personal relationships and problems in the workplace. And for many people in this room, this symptom profile actually may mirror another condition that we much more commonly encounter called frontotemporal dementia. And I think that if you want to kind of parcel the cognitive profile of HD, I think it's good to draw a comparison between this more commonly encountered condition of FTD, where you see a lot of these frontal and behavioural symptoms with impaired insight. But the context in which the HD person will present is often quite different, as there may be a long family history, the trajectory of symptoms may be longer, and there may or may not be associated motor features. To speak a little about the neuropsychiatric features, I suppose these are often cited in the literature as the most burdensome symptoms by family and caregivers. Apathy is a huge problem in Huntington's disease, and it can be present really early on in the prodromal phases of the disease. It's almost always progressive, and as the disease progresses, the apathy symptoms can actually become really disabling. Depression and anxiety are common, with depressive symptoms seen in up to half of people. And I think it's important to remember that depression and anxiety are likely to present in similar ways to the general population, that the management of these symptoms is the same as it is in the non-HD patient. So other symptoms such as impulsivity and irritability, when combined with those more frontal cognitive symptoms such as impaired insight and impaired motivation, can lead to huge problems socially, in the workplace, managing finances, being able to live independently. But this constellation of symptoms can also not uncommonly lead to people having interactions with the judicial system. So now we will speak just a little bit about family history in HD. This is a family tree taken from the Venezuelan kindreds that initially informed the phenotype, and often I think we'll expect to see this glaring autosomal dominant family history staring out at you, but actually sometimes it can be quite fraught, because family histories can be censored due to non-paternity, due to estrangement, or due to concealed diagnosis down through the years. We must scrutinise the family tree and look at diagnostic labels, so in particular where there are issues of suicidality, addiction or mental health problems, we must ask more about these. We also must remember the concept of anticipation, and that in late onset HD, people can present without having a family history at all. So despite the fact that this is an autosomal dominant disorder, de novo mutations are described in 5 to 7% of people. And with that in mind, I'd just like to briefly discuss a case. This is the first patient that I encountered with Huntington's disease as a trainee, and it really challenged my understanding of Huntington's disease at the time, and I learned so much from it, so I hope people here will also learn something from it. This is the story of a highly academic and motivated gentleman who spoke proudly of his achievements. He achieved a Master's in Law and successfully completed a PhD in Human Rights Law. Following completion of his PhD, he was unable to gain employment. He was unsuccessful at interviews. He became disorganised and unable to make decisions about his career. He spent the latter half of his 30s in unemployment. He began to smoke cannabis. He was described as having lost his drive. In his early 40s, he developed paranoid delusions, which led to a diagnosis of schizophrenia. And by his mid-40s, he began to decline functionally, unable to manage his affairs and unable to look after himself. He moved back in with his parents, who were healthy and well, and he was referred in for a medical assessment. At that time, his cognitive profile showed deficits in attention, working memory, and executive dysfunction. His psychiatric assessment demonstrated anxiety and obsessionality, and his neurological exam showed that his gait was slow and his reflexes were brisk, but there were no abnormal movements. Not until the age of 50 did he develop abnormal movements, where he was re-referred to neurology. His family tree showed that he was the eldest of 3 siblings. His 2 younger siblings were healthy. His parents were alive and well in their 70s. He had 2 paternal aunts with schizophrenia. Paternal grandparents died relatively young, in their 50s and 60s, of medical illness, and on his mother's side there was no history of neurological or mental health diagnoses, with maternal grandparents dying in their 70s and 80s of medical illness. So it wasn't until the development of Korea that Huntington's genetic testing was pursued and a mutation was found in the Huntington gene. So this case has always stuck with me because of the influence and the impact that this disease had on this man's life for so many years before a diagnosis was reached. And it always also serves to remind me that the apparent absence of a family history of disease and absence of a family history of Huntington's disease does not preclude a diagnosis. Okay, so coming to the end now, there's so much that we could talk about in terms of future therapies and directions, and in the last quarter of a century, since the gene was first discovered, our understanding of disease mechanisms has evolved so much, and with that has come greater potential for targeted therapeutics. But we don't have time to go through all of it today, but there is just one brief story that I want to speak about, and that is just to remind people that this is a time of real hope in Huntington's disease, and that, definitely there are huge advancements and evolution ongoing in the field of H2 therapeutics. So this is the initial success story of the antisense oligonucleotide in 2017. This is a single strand of chemically modified DNA. It has been shown to successfully be delivered to the brain, to the human brain, and to successfully lower levels of mutant Huntington in people with HD. While the initial trial was originally halted, a new trial has begun with a lower dose and a more select patient population. The interim analysis has been positive, and that is due to read out next year. So that comparison that I drew to the Wexler family and the modern day HD family will soon no longer be a valid comparison, because in the time span of our careers, we will see the opportunity to offer people with Huntington's disease treatments that will alter their disease course. But at present, of course, this is an incurable disease at this moment in time, but it is not an untreatable one, and recognition is key. And I think if there's only one thing that people take from today's talk, it's to remember that there are people with Huntington's disease who are in the prodromal or early manifest stages of disease, who have prominent psychiatric or cognitive symptoms, and they may present to memory services across the country at a time long before any motor features have evolved. And finally, the last thing I just want to say is about the importance of specialist care and support. We all understand that this is a rare and complex disease, and as healthcare professionals, we must continue to advocate for improved access to specialist supports for this vulnerable patient group. Thanks very much for your time.